start, I just wanted to thank 3PB Barristers and the Brain Injury Group for their support in helping organise and set up this webinar and sharing the information with their colleagues. So hopefully you'll all find this a useful session. I think we've got people joining us from all walks of kind of rehab therapy, medico-legal world. So hopefully it's useful. I guess to start, I'd introduce myself. I'm Emma Dewar, neurophysiotherapist. I have my colleagues Joanne O'Shea, neuro-OT, and Katherine Pierce, neuropsychologist with me. They'll be speaking towards the end of the presentation. And just to say that we have a lot of content around traumatic brain injury and the rehab involved in it. We've delivered 2-day courses on this topic. So we've tried to cram in as much as we can, but also not have it too jam-packed that we miss key messages. But at the end, we will also be asking you if there are any areas of interest, if people would like future webinars or other kind of learning forums. We'd like to hear your ideas. So yeah, just bear that in mind. So a quick whistle stop for those who don't know who we are at Hobbs. Hobbs is an independent provider of neuro rehab. We have clinical neuropsychology, OT, physio, speech and language therapy, rehab medicine consultants, and we offer a wide range of different therapy services, of which our concussion clinic or our mTBI clinic is one of them. Across the very many sites we now have, I think there are 9 on this map. We have slightly different services run out of the different sites, including some of our sites that offer inpatient rehab. The site that we are talking from is the South East Clinic, which is in Hampshire on the A3, just south of London. Our site is predominantly an outpatient centre and community, but we also do offer intensive packages and have some kind of intensive input into a care home locally near us as well. So for more information, see the website. We could talk about that for days. So moving on to concussion or mTBI, what is in a name? And I think it's really important to highlight from the start, the 2 terms mean the same thing. Concussion and mTBI will be used interchangeably throughout this talk. And actually the definition of a concussion is a traumatic brain injury caused by a direct blow to the head, neck, or body. So you don't have to hit your head to be concussed, because it's the impulsive force that is transmitted to the brain that is causing the concussive injury. And actually the CDC are recommending that we use the term mTBI, mild traumatic brain injury, when referring to concussion, so that it helps people recognize it with the kind of importance that it deserves. So the pathophysiology of concussion is quite complex. So I've only got a couple of slides on this. It's going to be a bit whistle stop, but effectively we have different densities of brain tissue. Our white matter and our grey matter have different densities. So when that impulsive force is transmitted to that head, to that brain, we get a stretching and a shearing of those nerve cells. It's not about bruising. It's not about a contra-coup injury, which is kind of old theories around the pathophysiology here. It purely is about the stretch, and that mechanical stretch, that mechanoporation of those nerve cells triggers off a neurometabolic cascade where we get a cellular exchange throughout all of the nerve cells in the brain, which then has a significant increase in demand for energy in the brain to help restore the balance of those nerve cells. Now, our brain energy, ATP, has been thought to decrease up to 20% following a concussion. And actually, as those brain energy levels plummet, it might not be initially straight away after that injury. It could be anywhere from up to 1 to 7 days before someone reaches their peak low of ATP. And that's why we often see this evolution of symptoms that happens after someone's had a head injury or a concussion. And typically most people's symptoms will start to resolve or improve as they come back up through that ATP curve within a week or so. But actually the studies have shown that even after symptoms have resolved, ATP levels can still be depleted. And it typically takes between 22 to 45 days for ATP to go back to its normal level. And therefore, we have these lovely concussion protocols that have come out in the sporting world to protect our athletes and put them through some testing and make sure they're not going back to their sport before 3 weeks. 21 days is normally kind of the cutoff points, because if they were to have a second injury, if you were to see that second red star there on the ATP curve, before their ATP levels have got back up to normal, we could be looking at another 20% decrease, and therefore a cumulative 30 to 40% decrease in ATP levels. And this is where we can actually get more structural cellular problems and damage in the brain. So it's really important that we take this seriously, and it's why the sports world are really taking the acute management of head injuries and concussion more seriously. So there are lots of proposed clinical correlations as to why people have the symptoms of concussion and what's actually going on in the brain. And effectively, at the moment, there's still very much hypotheses, but there is lots of research going into this to see what's actually happening to cause someone to have migrainous type symptoms or impaired cognition and slowed processing, slowed reaction times. And actually, the leading source of this research really is the sports world. At the moment, they're really invested in making sure they get this right, not only to get their athletes back to their sport quickly and safely, but also because there's been research in the past few years that's definitely found links between neurodegenerative disease and repeat concussion in former professional athletes. And I guess it's important to note that this is in former professional athletes. That's where these links have been made. And I'll often try to reassure our amateur athletes or general population who've had a concussion that there isn't research at the moment interlinking neurodegenerative disease with those one-off concussions. However, it's definitely something that is out there and is driving a lot of this research, which is actually great as a therapist. We want to know what we should be doing to help these people. There's also some current legal cases in professional sports, so it's a hot topic. And actually, we've been really fortunate over the past 5 or 6 years. We found we're in a really good place to treat mild traumatic brain injury because we're neurotherapists, and we've actually built really good links with a lot of musculoskeletal therapists and doctors, and have done work with a whole host of different sports clubs and teams, as you can see on here. And we're actually the direct referral pathway now for UK Sports Institute and all of their concussions, as well as doing lots of work with equestrian, sailing, British cycling. So yeah, we're quite fortunate in the fact that we get to see a whole host of these concussions and get to work with different therapists to get to increase our knowledge as well. And I guess the key thing really to mention here is the brain doesn't know whether it's had a concussion because it's had a bad rugby tackle or because it's been in a car accident. Fundamentally, concussion, mTBI, it's the same pathology. But I think as a team, we've also seen that it's managed very, very differently depending on who the patient has access to. And what we were quite keen to do today was to try and draw on the information and the knowledge we have from working with a whole host of different people from sports through the medico-legal world and also with our NHS colleagues to enable us to deliver the best for our patients. So I think quite a hot topic is often this debate between structural and functional. Is this a functional issue and these persisting symptoms that our patients experience, whether if they're not showing up on MRI or CT, then are they making it up? Is there anything going on? And I think actually there aren't any changes that we're necessarily seeing on MRI or CT, but these aren't really sensitive enough to be showing up what's actually going on a cellular level. And the newer research that's predominantly coming out of the sporting world is showing changes in cerebral blood flow, changes in delta waves with MEG scanning, white matter changes in DTI scans, cortical changes in TMS, and also there's some really interesting work around blood and salivary biomarkers to try and identify concussion acutely pitch side with that cellular neurometabolic dysfunction being picked up. So I think there's a huge amount of research going into what's actually going on. And I think this will continue to evolve over the next few years. And hopefully we will be in a better position to identify exactly what's going on for our patients. So I guess at the moment, the research is really indicating that there probably is a structural and a functional, a dysfunction of the nerve cells that is happening post-concussion. But it is important to highlight that the current research has found correlations between these changes on scans and symptoms and delayed recovery, but the causation is still a bit unclear. So because we've seen something on a scan, we're still not entirely sure, is that concussion, or has it been compared with someone perhaps who's migrainous or who has chronic pain? And I think therefore there is still this need for more robust evidence, but I guess my message is watch this space. I think it's certainly going to be evolving in the next few years. So what's important to us as therapists here? What do we want to do to help our patients? And actually, it'd be great to know if there's anything on scans, but it's not necessarily going to change what we're doing in our treatments. And we know that persisting concussion symptoms, which is termed those symptoms that last over a month post-injury, are actually part of a physiological brain injury. The concussion produces cerebral and systemic effects within the body. And actually, there's some really nice kind of teaching and things coming out of Canada and the States, which is helping us to compartmentalize this into systems. So as opposed to us looking at the symptoms of our patient and trying to treat a headache, what we want to do is try and identify, well, what's causing that headache? Is it an autonomic problem, a neuroinflammation problem, a visual vestibular problem? Is it a neck problem or a psychological problem? And actually, by understanding these systems, we can help our patients unpick their symptoms and treat them. So from a physio perspective, it's really nice. We have the Quatman-Yates et al. Document, which is the physical therapy guidelines, and they kind of tease it out a little bit more into what we as physios can treat, which would be the cervical spine. And I think this is an area which patients are often referred to. We know that the neck and the headaches and the whiplashy component of the injury can benefit from treatments, but we don't always see people being referred for vestibular and ocular motor assessments and treatments, anyone investigating autonomic or exertional problems, or looking at that overall motor control, balance, and sensory processing. So, system one, the autonomic system and dysregulation. So, as you know, the sympathetic nervous system mobilizes our reserves under stressful conditions to give us increased blood flow and energy and supply when we need it, when the demand is more. It's our fight-flight system. And then we have the parasympathetic nervous system, the opposing branch of it, which is our rest and digest system, responsible for homeostasis. And these systems should be really well balanced. We should be able to access both of them. And there's a good body of research now showing that actually the autonomic nervous system can become dysregulated following a head injury. And we commonly see, not always, but commonly see people get tipped into more of a sympathetic dominance. They're more living in that fight-flight zone, struggling with issues that look a bit more like anxiety, but actually could be affecting their sleep, their thinking processes, and actually on a physiological level, affecting their ability to exert themselves and exercise. So the research has shown that there is altered cerebral blood flow, abnormal heart rate variability, changes in neurovascular coupling, and also abnormal reactivity to changes in CO2. So it really is that kind of neurovascular connection that is dysregulated. And a lot of this research has been based on exertional studies. What we can really nicely do in clinic, and this is a test that is really commonly used now throughout kind of MSK in the sporting world post-concussion, is the Buffalo Concussion Treadmill Test or bike test. You can do it on a treadmill or a bike. And the principle of this test is we're looking at stimulating that sympathetic drive by exercising on a ramp test. So someone's walking on a treadmill and we increase the incline, or they're cycling on a bike and we're increasing the resistance. At the same time, we're monitoring their heart rate and monitoring their symptoms. And if at a certain level, say they get a heart rate of 150 and that's when their symptoms start to kick in, we would stop the test at that point, and that would be termed as their heart rate threshold. We would then be able to prescribe exercise, and that's the treatment approach for this system from a physio's perspective, prescribing exercise just below that heart rate threshold to help their system recalibrate. And actually, programmatic exercise as early as 24 to 48 hours is actually been found to be safe. Physical activity with this graded light cardiovascular prescription has had really, really good results in the research and has helped speed up return to sports in the sporting world. But certainly it's a system that we'll be looking at in any of our patients, whether they're an athlete or not. For the second system, actually, just go back. The other part of that system, the parasympathetic nervous system, obviously we would be prescribing exercise, but we may also be prescribing some parasympathetic type exercises. And in a physio's brain, that's how I'd term it. My psychology and OT colleagues might term it something different. But this could be yoga, mindfulness, breath work, things that are helping them access that rest and digest system. So it's all about balancing those two systems. So neuroinflammation is the second system that we might be suspecting is problematic. I would actually say this is quite a tricky system. This is typically our patients who present with that more migrainous profile, where their symptoms are linked to those sensory sensitivities, light sensitivity, sound sensitivity, that kind of foggy, fatigue type presentation. And actually, there's a lot of research connecting the brain and the gut. So we know that our migraine sufferers often will also suffer from IBS. There is a direct connection between those two systems. And the inflammatory response that happens in the brain can trigger the microglia to trigger a more systemic inflammatory response within the gut, which then becomes quite cyclical and perpetuates. So this can be a system that is managed with a whole host of different techniques, but I think it's really important that some of these symptoms to tease out with your questioning with your patients or your clients and see if there's anything that would fit this profile, because we need to understand it so we know how to treat it. And typically our management would first of all include a lot of education, understanding that we've triggered some post-traumatic migraine. And actually migraine isn't just about headache. Migraine is an umbrella term for a whole host of symptoms that are neurological symptoms, whether they be dizziness, visual symptoms, sensory sensitivities. We may be referring on to our neurology colleagues, linking in with them about medication management, of how we can best minimize the impact of these symptoms, as well as doing some work with the individual to help them understand their triggers, what lifestyle modifications or diet and hydration might be able to help them, as well as sleep and pacing. And that's certainly where my OT and psychology colleagues can be really, really useful in helping manage this system. So the third system I'd like to talk about, the visual and vestibular system. And these two systems are really, really closely linked. I have slightly teased them out into two separate systems, but I would pretty much say I always would be treating these simultaneously. So the visual system, the sorts of things that patients might be reporting are light sensitivity, ocular pain, double vision, blurred vision. And understandably, these sorts of symptoms are going to have a huge functional impact, whether that be on someone's concentration, their reading, their screen tolerance. And often the impact on things like driving or return to work can be huge. So it's a really important system to recognise. But as I said, it's so close.
A bit of water come out to start, and at first it seemed fine, and then it started to drip.
Someone's turned their microphone off, on. There we go, we're gone. So it's really important to recognise that the visual system and the vestibular system are really closely linked. Vision rehabilitation, there are some really good options out there, whether it be optical devices, vision therapy, or a combined approach. But I think there is a slight lacking in the evidence base for visual rehab. And I think certainly in the UK, we don't have a lot of neuro-optometrists. So it's a slightly trickier rehab service to access. I would say that actually part of vestibular rehab does involve the oculomotor system. So on a basic level, physiotherapists can involve some components of vision therapy into their vestibular rehab, but will certainly be able to flag up if an onward referral to some more specialist vision therapy is required. And from a vestibular perspective, I've teased this out into the central and the peripheral vestibular system. By the peripheral vestibular system, I mean your little spirit level that lives in your inner ear that detects movement. And actually, some studies have found up to 26% of patients with persistent dizziness after a concussion had a peripheral vestibular problem called BPPV. And you may be quite familiar with this. It is a condition that can occur in the whole population for a multitude of reasons, but actually there's a high incidence of it post-head injury and post-trauma. And BPPV, for anyone who doesn't know, is a really, really treatable condition. It's where the little crystals in the inner ears get dislodged into the wrong part of the vestibular system. And within 1 to 2 treatment maneuvers and positional changes, we can actually correct that and get rid of these symptoms. So it's a really good one to look out for. We actually see it quite a lot in our clinics with persistent patients, and it's been missed. So a really, really good one to screen for. And then central vestibular dysfunction. And I think it's important to recognize that the visual and the vestibular system have a wide range of vestibular and visual nuclei throughout the brain. They are so highly integrated and connected with our motor control, with our movement patterns, our spatial awareness, our memory, and therefore the stretching and the cellular changes that happens in the concussion can disrupt the messaging of these sensory systems, which will give us these more generalized symptoms of dizziness, instability, feeling like they're not quite in sync within the world. And there's some really lovely screening tools that have been developed in the sports world. The VOMS, the vestibular ocular motor screen that I've put at the bottom there, is a really nice screen that you might be able to easily integrate into your practice to help pick up some of these problems and then make onward referrals. I also just wanted to point out a nice paper, the Brodsky paper. This is actually written from an audio vestibular medicine perspective, just trying to pick out when you need to refer on to see an audio vestibular physician for more structural and formal testing, which the 3 key questions: does someone have oscillopsia, which is a sense of an unstable visual world? Do they have hearing loss? And this is a new acute hearing loss that has happened around the time of the injury. Or do they have sound-induced vertigo? So where sounds trigger dizziness. Any of these symptoms would be making us think, there might be something structural going on here with the vestibular system. Let's refer on. But actually, if it's a no to those questions, and we've got more of a motion or exertion triggered dizziness, then absolutely we can refer on to physiotherapy, neurophysiotherapy, to investigate and see whether it's a BPPV, whether it needs a buffalo test, or some vestibular rehab or migraine management. So do use that paper. It's quite a nice one to help you screen your patients. I think it's also key to highlight dizziness and return to work are very closely linked. And it's been identified as an independent predictor of a failure to return to work, as well as links with psychological distress. These invisible, dizzy symptoms are horrible, and no one else can see them. So it's quite difficult for people to manage them. So vestibular rehab is great, in my opinion, because it works. It's really, really useful modality for reducing those symptoms of dizziness, vertigo, and improving someone's balance and motor control. And I think, as with any of the principles of rehab, we're not on silent again. Thank you, Lucy. We want any treatment plans to be individual, specific, and graded, particularly if someone's very sensitive. And there are vestibular services out there who may just give a standardized 6-week program protocol, off you go. It can work in a select population, but actually I would typically say my concussion and mTBI patients are quite sensitive and they do need a more individualized approach. It's really important for us to also incorporate this with our visual interventions as well as our cervical spine interventions. That multimodal approach has actually got some really good research. So moving on to the neck, the cervical spine, the acceleration and deceleration injury doesn't just affect the head, it's obviously going to affect the neck as well. And it's hypothesized that the G-forces involved in concussion are much higher than those involved in whiplash or neck strain. So actually, you could say anyone who's had enough G-force to be concussed is likely to have a simultaneous whiplash or neck problem. So it's really important to look out for this. And I think commonly people are referred to musculoskeletal therapy, particularly if they're having neck pain or headaches. But it's also important for this to be looked at in a combination with the other systems and whether the neck, the visual and the vestibular systems are integrating properly. And a bit of research from the whiplash and mTBI kind of world, which was looking at measures of attention, memory, visual, spatial and executive functions. And it actually found that both whiplash and mTBI patients had problems within those areas, and it didn't differ significantly. So I guess this kind of highlights to us, well, we need to treat the whiplash, we need to treat the mTBI, but also if someone's got cognitive symptoms, is this a cognitive deficit here, or actually is this a whiplash that we need to treat that is at the root of depleting that person's cognitive reserves? So I think it's really important to look holistically when someone's reporting their symptoms. So from a neck perspective, we've got lots of treatment options, again, targeting the individual's specific dysfunction. For instance, the lady in the photos on the right there was a cyclist. So we progressed a lot of her strengthening and cervical spine treatment to be in upper limb weight bearing, which helped prepare her for getting back onto the bike for the endurance races that she was participating in. So these systems, as we've said, are very closely integrated. The vestibular, visual, somatosensory, and also our thoughts and beliefs and kind of previous experiences of what movement feels like will all feed into that grey box in the middle, which represents your brain that interprets those messages, those signals. And it could be that there's a problem with the inputs on the left, or it could be that there's a problem with the grey box and how it's interpreting and calibrating that information following a concussion. So what we need to tease out is, where is the system dysfunction, and can we treat that to then help the outputs on the right, which are our awareness of movement, our eye control, our motor control, our posture, and our autonomic responses. We often do see maladaptive responses, and I think the classic presentation in this group is that there's perhaps a stiff neck, which is influencing the somatosensory information, as well as then they're not moving their head enough to optimize their vestibular system. Throw in a BPPV as well, and then we've got someone who's really going to switch to relying on their visual system to help them balance. If someone becomes visually dependent, that will mean that system gets really overloaded and easily fatigued, which can then mean things like screens, driving, visually busy environments are really problematic. So you can see here how we have to untangle which system it is, and visual symptoms don't necessarily mean we're going to treat the visual system. It might be that we need to treat the neck. So yeah, it's being a bit of a detective, I think, with these patients. And the fifth system, but by no means the least system, probably should have been number one on my list, is the psychology of mTBI, or any injury really, because psychology is the foundation of any rehab journey. And unfortunately, it can sometimes be linked to mismanagement or misinformation from well-meaning people in the early days, or linked to pre-existing factors, or that kind of unavoidable, and kind of we shouldn't downplay the connection between our mind and our body. And actually, how we're feeling physically, how we're feeling emotionally and mentally will influence each other. And I'm going to stop making a hash of the psychology section and pass it over to my wonderful colleague, Dr. Katherine Pierce. We're just going to switch seats to talk about psychology.
Hi, so thank you, Emma. That was really helpful. So I'm Katherine Pierce. I'm a neuropsychologist, and I've been working jointly with my physio and OT colleagues at the Hobbs mTBI clinic for almost 3 years now. I also regularly assess people who've had an mTBI in medical legal settings as an expert witness. And I see a diverse range of presentations across both contexts. But what I would say is that it's my work here at Hobbs, working closely with my colleagues here, my physio colleagues in particular, in terms of, has it helped to refine my understanding of the different systems that I really do need to take into consideration when I'm formulating why it is that somebody is, oh, sorry, I've scrolled on too quickly. There we go. So yes, so when I'm formulating why it is somebody might be presenting with persistent cognitive symptoms, in addition to emotional distress or mental health difficulties. There we go. So today, what I'm going to be doing is describing some of the ways in which psychological and social factors can affect the expression of persisting concussion symptoms, and why it can be so important to address these issues collaboratively in order for treatment to actually be effective. So when somebody steps into our assessment room, we are immediately collectively trying to make sense of who this individual person is, and actually, really importantly, what does the head injury and any persisting symptoms mean in the context of that individual's life? Who is this that we're meeting, and what does this injury and the symptoms mean to them? So what you will see on this slide here is that there are many different aspects that we need to take into account when making sense of what might be maintaining somebody's anxiety or cognitive symptoms. So, for instance, past experiences, we'll be asking whether or not somebody had a previous concussion and what their experience of recovery was like for that, because that will also kind of inform what their expectations are going forwards. Previous trauma symptoms also are relevant here, because if somebody has pre-existing psychological trauma, then an experience of an injury like this can reignite previous long-standing trauma symptoms and interact with the anxiety that they experience in relation to the symptoms. Emma really helpfully before said that the brain doesn't know whether the injury has been acquired in a rugby pitch or in a road traffic accident. However, the whole mind-body issue becomes to the fore here because actually individuals do know, and that affects the meaning to them. So a rugby player, for them, a concussion perhaps is part and parcel of being a rugby player, and therefore the symptoms of concussion are worrying insofar as they want to get treatment quickly and go back to work, but perhaps have a greater expectation that this will recover and it's not threatening. Whereas somebody who perhaps isn't assessed quickly, who experiences their symptoms in the aftermath of a road traffic accident or an assault by a stranger, will perhaps construe their symptoms very differently. We also need to take into account what any persisting symptoms mean for people's roles. So for an athlete, it might mean I might not get onto the first team.
Thank you. No, don't worry.
So just need to get treatment quickly so that I can return to play as quickly as possible. But it might be that somebody who is a parent begins to really worry about how they're interacting with their children, and how they're perhaps avoiding engagement on that front. Somebody who is working maybe on a self-employed basis or 0 hours contract, who hasn't been able to get to work, back to work because they're dizzy, may then also be worrying about other factors, about how can they pay their bills. One of the questions that we always find to be very useful in our assessment stages is, what does the person believe is the reason for their persisting symptoms? What thoughts, interpretations, attributions are they making about the symptoms that they have? Because if we can understand what sense they're making of their symptoms, we can perhaps then understand whether a simple education intervention might be useful, or I'll give you, I think the best way to illustrate that is to give you a really good example, actually, in that when we asked one young woman we were assessing what she understood to be the reason for some of her symptoms and dizziness, she said that she had seen in her scan, we believe it's an MRI scan, black holes, and she thought that she had a significant brain injury and that this was causing her symptoms. And we were able to explain that what she was describing was actually the ventricles, and that was an entirely normal presentation. And just simply asking that question sometimes can lead to a very simple dispelling of a misattribution and misinterpretation. Also, cultural factors are relevant as well, because as I've already said, somebody in a sporting field may feel much less threatened by post-concussion symptoms than perhaps somebody who feels that any persisting symptoms may be in some way a punishment. We have seen that happen here. Right. So just take a sip of water. So in my joint assessments with the physiotherapist, I'm immediately asking what relevant factors before, during and after the injury do we need to be taking into consideration? We know that cognitive complaints are really common. Subjective cognitive complaints are really common post-concussion. People will often describe difficulty sustaining their attention, feeling distractible. In fact, people will often describe a brain fog. And what's really interesting is that people will often say that when they're refreshed and in a quiet and demanding environment, they might function cognitively at baseline, but that using screens or driving or being in busy street environments quickly depletes their resources, and they begin to find that cognitively they can no longer function. And as Emma's already described, we can understand why that might be the case if somebody's also presenting with dizziness, balance difficulties, migraines, etc. There we go. So research on mTBI and cognitive difficulties has been very variable, but a recent review, a systemic review looking at a whole range of studies, basically said that commonly people are experiencing problems with attention, memory, and executive function. And our research would identify that this is also an association, as Emma has said, these are things that are associated with mTBI. We do not necessarily know this is causation. We don't yet have sufficient longitudinal information. But the research has identified that pre-existing mental health conditions, multiple concussions, age and gender are all relevant factors. But very few of the studies in the UK break the mTBI population down into groups with and without the presenting dysfunctions described by Emma. So when looking at cognition in the context of mTBI, quite often that doesn't break down the mTBI group with these people who present with PTSD and mTBI or without. So when we're looking at cognition and concussion, often the research looks at very mixed, diverse groups. And therefore, if we're looking at very mixed, diverse groups, people who have PTSD mixed up with people with vestibular dysfunction or migraine, we should really be expecting very variable findings. And it's not surprising that in 2015, the neurologist Sharp and Jenkins wrote a paper called Concussion is Confusing Us All. But what the research has shown in looking at cognition and mTBI, what the research has shown, if we separate out mTBI, it's clearly established that absent a concussion, vestibular dysfunction alone, peripheral vestibular dysfunction, is strongly associated with visuospatial impairments, attentional difficulties, memory problems. And there's a really good paper written by Guo et al. In 2024, which actually makes clear that this is not something that is taken into consideration sufficiently in the UK in our treatment of mTBI. Migraine, major depressive disorder, both clear research databases showing that these presentations are associated with attention and concentration difficulties. And PTSD also has very pervasive associated cognitive deficits. So what I think is important to consider when we're looking at cognitive burden, subjectively described cognitive symptoms post a mild traumatic brain injury, is that this is so much more complex than a pathophysiological structural brain injury or a psychological response. There are so many other factors, such as the vestibular function and visual dysfunction, that we need to take into account, because these will mediate somebody's response to their symptoms. So we need more sophisticated models and formulations to understand why it is that some people, a significant minority, do experience persisting symptoms. And we all have a finite attentional capacity. There's a huge variation with all of us. Some people can work with music in the background, some can't. So we have many demands on attentional capacity post mild traumatic brain injury. Somebody with post-traumatic stress disorder will be needing to scan the environment for threats if they're feeling traumatized. people managing dizziness and balance are concentrating very hard on maintaining their safety while out and about, will not have the same level of resource as somebody who just walks unconsciously without thinking in any way about what they need to do to stay upright. It's inevitable that in the context of unpleasant symptoms like dizziness and headaches and fatigue and cognitive dysfunction, that individuals become worried, and especially in the context of untreated persisting symptoms. And it's often the case that I see in my medical legal work and sometimes here in the clinic that people have been sitting at home told that their symptoms will resolve if they just rest within 3 months. And when those symptoms don't resolve, people begin to really worry. Will I ever get back to work? Will I recover? It affects their sleep. If people can't sleep, they become increasingly fatigued. When people become more fatigued, their cognition is less effective. They become more stressed, and that interacts with vestibular dysfunction, etc. So if left untreated, if left untreated, basically people can really begin to experience a significant level of cognitive and psychological overlay, which needs to be unpicked, which is why, just to sum up here, that this is why a multidisciplinary assessment that is thorough is so important, because it guides both the neuropsychological treatment and the collaborative multidisciplinary treatment. If we understand that somebody has an erroneous health belief, we can intervene quickly. If somebody's vestibular symptoms are inflamed because they are avoiding provocative situations, becoming phobic, psychologists can work closely with the physiotherapists to gradually sort of a graded return to activity, sport, work. And Jo will discuss her role in considering a return to vocational activities as well. There's a very clear evidence base for the treatment of PTSD in the context of trauma, and we've discussed sort of vestibular treatment. And that might need to be a kind of a CBT approach to accepting any persistent symptoms in the long term. All of these issues can occur in one individual person. It might be that people need a lot of different interventions on their journey to make better recovery from a mild traumatic brain injury, but it needs to be collaborative. It might be that somebody cannot engage in their vestibular program because their anxiety is too great, or that CBT work and EMDR work for PTSD is too provocative of dizziness, and therefore we need to work with the vestibular physiotherapists. So at this point, I'm going to hand over to my colleague, Jo. I put a link in your slides to the Register of Clinical Neuropsychologists, because I know that they're not always easy to identify if you're not working with an MDT that contains a neuropsychologist.
And we will send out the slides, everyone, just so you don't need to worry. And I should have said that at the start, so you don't need to make notes.
Yeah, and I'll hand over to my OT colleague, Jo O'Shea now, who will discuss more about her role within the team at Hobbs.
Thank you, Katherine. Hello, everyone. You're all there somewhere in the screen world. And my name is Jo. I'm an occupational therapist here on the team. I'm very lucky to be working here with Katherine and Emma and the wider team. So why refer to occupational therapy? I'm probably making the assumption that a lot of you know an OT, maybe are an OT in your case management roles. But essentially, I come to the practical elements and how are we going to get this person back to living their lives? And I'm interested in their 24-hour occupational profile. So what motivates them? What habits do they have? What responsibilities? In what context and family situation are they? Really is important in terms of fitting this rehabilitation in. So I'm particularly interested in sleep and helping them to get back onto a good sleep regime. But I even break it down to things like, are they able to drive? Are they able to drop the kids off at school? How are they managing if they try and get a social interaction and go into a busy cafe and the world is screaming at them because of that sensitivity brain? And right back to kind of the seriousness of, actually, I need to get back to work. And so if I really struggle to manage 10 minutes on my screen, how on earth am I going to return to kind of my job that has 7-8 hours of being in front of a laptop? So it's a really crucial part, and it's where I tend to step in on the MDT here at Hobbs. So who you might refer to? Well, the literature says it's those at risk for poor prognosis should be indicated for MDT input. So we'd be thinking about people with a high symptom severity score when they do their questionnaire before coming to us, or those demonstrating sleep disturbance. It has been shown that if you have a still interrupted sleep post-injury 10 days, you have got a likelihood of poorer recovery outcomes. And definitely what Katherine's been alluding to, and about those fear avoidance behaviours, that can get really, really problematic when people try and increase their activities, but they get stuck because they end up feeling more rotten. So we build a stepping stone out of those kind of situations for people. OT is very well placed for helping people to manage fatigue and live with symptoms, but also achieve their basic to-do list in terms of planning, pacing, organising their time. And again, as I said, if you're getting to the point of 4 weeks after and symptoms are still persisting, we need to start thinking about getting referred to a team that can look at someone's experience in the holistic way. So in my practice, when I meet the clients here, we see oftentimes they will have already had an unsuccessful return to work. And that can be really troublesome in terms of their confidence, and it can kind of grow that kind of rumination and grow that kind of fear and worry and avoidance. So we like to actually do a phased return. We could do that actually proactively. So the first time they get it right, because we've helped to educate and liaise with their employers. It's a lovely part of the step to get involved in. But people tend to get stuck, as I've said, when they might be given more rehab to do, and then they might have more responsibilities at home, and then just that accumulation of tasks in their day just becomes too much, and they get nasty symptoms, and they kind of get small again. So people tend to fall into the kind of either trap of fear avoidance, or boom and bust, and like, oh, it'll be fine, and go way too much either in their work capacity, their parenting capacity. They don't delegate, and then they fall into the trap of like bust and maybe accruing sick days, and really they start to get on a bit of an unhelpful kind of trajectory. I've definitely noticed that the integration changes, so rehabilitating someone's global systems and sensory inputs, it takes time, and it needs to be slow and gradual. And I kind of weave that into the communication with them about returning to work. Oftentimes they'll go back to 2 days a week, and then next week will be 3, and then it'll be full time. We tend to go a bit slower and steadier, obviously depending on their on the severity of their experience, but slow and gradual tends to work. And we're really kind of helpful, I hope, in occupational therapy at troubleshooting and managing these setbacks. So I'm going to kind of walk you through some of the research I was looking at when I got curious about returning to work and mTBI. There isn't a whole lot of research done in the UK. It all is outside of the UK. There was a big study in 2022 by Gaudet et al. That was a US cohort study called Track TBI, and they tracked 435 adults in the first year after having a mTBI, and they found that 59% were not working after 2 weeks, and 17% were still not working after 1 year. Now that's a minority, but still quite a significant minority. And really importantly, and I guess this is where it could kind of weave into other off spills, is that during the first year work, the status had declined, and annual income had reduced for 21% of people. Conradson et al. In 2024, this was a Danish study which interviewed employers and employees in the first year of post-mTBI, and 3/4 had returned to work under similar conditions, but therefore there was 25% that hadn't been able to manage that successful return to work, and their hours had reduced quite notably from 36.3 hours to 17.6 hours. So it was a relatively small study, but quite important data came out of there, I thought. Staying in work with TBI is obviously the goal, what we want. Theodom et al. Back in 2017, it was a US study which looked at individuals and followed them 4 years post-mTBI. And they looked at people's employment status after 4 years and their work productivity. And after the 4 years, 17.3% had left the workforce or had reduced their working hours, and 15.5% reported experiencing limitations at work because of their injury. Now, what I found quite interesting was the finding that when people reported the symptom of taking longer to think 1 month post their injury, this significantly predicted their work productivity loss 4 years later. And I think with new eyes of what Emma and Katherine we've been explaining about is that we must be careful to rush to, oh my goodness, taking longer to think is the problem. Actually, we could maybe rehabilitate some of the symptoms to free up that kind of thinking space and that attentional reserve people have. So actually that helped me feel quite hopeful that we could help with people's work productivity by rehabilitating them. This study by Graf et al. In 2019, this is a nationwide cohort study in Denmark of patients with mTBI. So they were registered on a national register and had a 5-year follow-up. There was 19,000 participants and 18,000 controls, and they'd excluded people who'd had previous mTBIs or brain injury or neurological conditions. And they looked kind of in a more global population level at the primary outcome of someone not attending ordinary work. They defined this as if anyone was receiving employment benefits in that 5 year, after that 5 years, they were not attending normal work. And they found that after 5 years, 43% were not attending ordinary work and were receiving employment assistance of some type. Actually, they found that you were 22% more likely to receive health benefits in their Danish system. So whilst this is absolutely not a causational study, it looked on a population cohort basis, and I think it kind of gives food for thought for the kind of ripple effects that mTBI can have in the vocational world. So the predictors of difficulties in returning to work, again, from the literature, a couple of points came up. The number of symptoms were actually found to be significant in a Gaudet study. So they found that 73% of patients with 3 or more acute symptoms reported they were working at 12 months after injury, but a higher percentage of 89% who had 2 or fewer acute symptoms had returned to work. So even that 1-2 symptom number jump was significant. Symptom severity and psychological distress were found in themes by Koning et al. In terms of affecting someone's success in returning to work. And Emma alluded to dizziness actually being a predictor. So they're starting to make the links. I've dropped in the kind of exploration of what kinds of work might be more susceptible to mTBI injury and successful return to work. And the jury is still out. Graf did a study in 2023, and they landed on the kind of conclusion that individuals with high income and management experience might be more affected. Whereas back in 2006, Walker proposed that manual labour occupations report more difficulty. I think in clinic I've seen people from all kind of walks of life, and in their own way, it's problematic. So I don't break it down too much when I see people that way. But fear avoidance behaviour is all over the kind of literature in terms of getting back to work post mTBI. Snell et al. Found that 53% had returned after 6 to 9 months, which is not a massive number. And I think it was interesting, they found that early fear avoidance, so when you're feeling rotten acutely, that's okay. It was weakly associated with return to work success. But those with persisting or increasing fear avoidance, they were more likely to be off work at 6 to 9 months. So getting rehab in during that kind of vulnerable stage where they're trying is really key. And the challenges that were quoted as like, oh, this is what's getting in the way of me being able to get back to work safely, sustainably, and productively. They included actual reports of decreased work productivity, was reported by up to 65% of candidates in one study. And when they kind of interviewed employers, they quoted difficulty assessing the number of hours someone should go back on and when. They didn't feel very informed about what does what can concussion do to this extent, and they really struggle to kind of reallocate maybe tasks or roles to that person as they're doing their phased return. And 42% of employees reported making more mistakes. So that's typically what I see in clinic as well. And we just kind of normalize it, but we wrap it up in their MDT rehab, and we inform their team around them that we can get through this. A qualitative study, I thought, landed on three really important themes. One was that they found the GP hadn't referred on or provided adequate guidance or treatment. Some employees perceived they were met with distrust from management, and they really landed on the outcome that people were referred to rehabilitation too late. So they'd already maybe had 1 or 2 even failed returns to work. But the good news is intervention is effective. So back in that track TBI study at the start, they found that participants offered employer assistance in the first 3 months were more likely to be working than those not offered. So after 12 months, 72% of those not offered support were back at work, but this jumped to 86% of those who had support early on were back at work. And kind of what reassures me is that it's not highly complex kind of reasonable adjustments. It's sick leave, reduced hours, a modified schedule for a time, transfer to different tasks, and assistive technology. And that's what kind of I wrap into my kind of support in getting people back to work. I'll quickly, I'm aware of time, but I'll quickly just introduce a case study. A was a 32-year-old GP in training. She was very active, enjoyed cycling, being out in the Peak District. And we met her 10 months post her injury, and she had an unsuccessful return to work in her GP training program and had significant fears for her career potential. And physically and just holistically, she was experiencing blurred vision, head pressure and headache, fatigue, reported cognitive processing difficulties, sleeplessness, visual and motor sensitivity, and quite significant mood difficulties. So that was a full MDT input. And I'll just whiz you really quickly through some of the main categories of what you would expect OTs to get involved with, but it was education. It was really pulling out the kind of problematic areas around her sleep and her behaviors. Graded return to activities of daily living. I'm talking cooking, going back to the kitchen, being able to share, the sitting room with her housemate. Things were that small. And we steadily got her introduced into a return to work hardening program, and that also involved letters to Occ Health, having a meeting with her line manager employer, and really phasing out a gradual return to work. And I can happily report she did return to her GP training. We've got loads of examples, we just don't have time to speak to them all today. But in a nutshell, we really just we really champion the referral to an MDT. And once they reach an MDT, that can just also spiral off other helpful referrals like to neurology, audiovestibular medicine, or optometry. And recovery is, early initiation is associated with faster recovery after concussion, and active rehab programs are shown to be safe and be of benefit in facilitating recovery. I'll hand you back to Emma really quickly before we let you go.
Thank you all. I'm sorry we slightly run over. We started a little bit late to let attendees join, so we figured we'd run a couple of minutes over towards the end. I guess the one thing we'd be interested in, obviously this is whistle stop. If anyone has any other questions or would like some ongoing learning, we are looking to maybe put together future webinars or conferences, in-person courses. Please do put any requests you have in the chat on this meeting now. That will be really helpful.